Hello. How are you?
Hi, how are you?
Good. So I had sorry, I'm in Nigeria and I had some technical difficulties. And Dr. Mela, she's associate professor of medicine at Harvard Medical School. She is at the no, she's at Mass
At the
General.
Mass General, yeah.
Yes. And she basically loves all things devices, but also she's interested in some SVT stuff and was very instrumental in our most recent trip to IDIS, helping with setting up the EP equipment there and doing some ablations. And so it is my honor to introduce her and to see what she has for us about SVT diagnosis and treatment, particularly since we are doing a lot more, not just in Nigeria, but across.
Hi, everybody. Hello from Boston and 28 degrees Fahrenheit. I hope it's a little warmer where you are. My task today is to talk about SVTs, supraventricular tachycardias. Depending on your background, many of you may find a lot of things familiar, but I thought to start with let's see if I can move. Okay, great. The basics, and then we'll talk more about more detailed stuff, more detailed in regards of what we do as electrophysiologists, and I will answer questions at the end. Feel free to send them to the chat box or the Q&A. The epidemiology of SVTs, about 2 to 3 persons per 1,000 persons. Women have twice the risk of men developing SVT. Individuals older than 65 years of age have 5 times the risk of younger persons. Persons who are referred for ablation are younger, have a similar sex distribution, and have a low risk of cardiovascular disease. Women have a higher incidence of AVNRT, and I will do a refresher about what that abbreviation means. And the incidence of WPW pattern on EKG is 0.1 to 0.3 in the general population, but not everybody has WPW syndrome. In terms of the SVT distribution by age, we can see with the open bar AVRT, so SVTs that are related to accessory pathways. They peak in the teenager years and continue to happen in younger adults, but then as the age advances, we see fewer of them. While AVNRT is in the gray bar, is really an SVT of the middle age and older people. And atrial tachycardia is a less frequent arrhythmia, both in younger and older people. How do patients present? Very commonly, palpitations, but it could also be just episodic lightheadedness or dyspnea, or rarely syncope. Pathognomonic really finding for AVNRT is when the people describe a throbbing in their neck. There could be also a lot of other atypical symptoms like anxiety. I have met young especially females that had been on anxiolytics while their true diagnosis was SVT. It could be episodic fatigue, nausea, general malaise. For people that may have coronary artery disease, it can present as chest pain or heart failure or tachycardia-mediated cardiomyopathy. We talk a lot about WPW and the small but existing risk for sudden cardiac arrest or death, which may be up to 0.15% per year in patients with symptomatic WPW, while it could be up to 2% per year for non-lethal cardiac arrest in various series. The workup, when we first meet a patient with palpitations, of course, will include a 12-lead EKG that will tell us whether whether a WPW, for example, pattern exists. We will check electrolytes. Hypokalemia, hypomagnesemia can trigger SVTs. They don't cause them, but they can trigger them. The same with anemia, the same with high or low thyroid function, digoxin levels for patients who may already be treated for SVT. And really helpful is to get an echocardiogram to make sure that the patient does not have structural heart abnormalities, congenital heart disease for young adults, where the SVDs can become more complex in terms of managing them with ablation. Also very helpful is, if possible, to have an ambulatory monitor, especially for patients who get their symptoms frequently, daily, or once a week. Giving them a monitor where we can capture the episode is going to be very helpful. And then, of course, the EP study, the electrophysiology study, that is what I do, and we will talk more during the course of the discussion. Now, the mechanisms of SVT, there are really 4 possibilities, really 3 possibilities plus the flutter. The AV nodal reentrant tachycardia is the most frequent one, 50 to 60% incidence rate. So when I see in the emergency room someone who came with palpitations, and it is a woman who's 55 years old and her palpitation started a year ago, it is almost certainly AV-NRT, even without having seen her EKG. AV reciprocating or reentrant tachycardia, the one that is associated with the presence of an accessory pathway, is a little less common, 30 to 40%. Atrial tachycardia, much less common, 10%, and atrial flutter, about 10%. The atrial flutter, we sometimes group it together with atrial fibrillation, but it is really an SVT. Let's start with the most common first, AV-NRT. It usually presents after the age of 20, but we can still see it even in pediatric cases. As we discussed, it is more frequent in women, about twice as frequent. The neck pounding we mentioned. And in most of the cases, it is what we call typical slow-fast AV-NRT. So I will ask you to concentrate on the first part of this diagram, which represents the AV nodal reentrant tachycardia. So if the sinus node is up there in the right atrium, the AV node in the junction between the upper and the lower part of the heart, the people who have AV-NRT are born with what we call dual AV nodal physiology. So the AV node is not just one compact pathway, but it has 2 pathways, one slow and one fast conducting. Every sinus beat usually goes down the fast pathway, but under special circumstances that a premature atrial complex or a premature ventricular complex can create, the conduction down the fast pathway blocks because the pathway is refractory, and the beat finds its way down the slow pathway first, and by the time it arrives to the junction where the slow meets the fast has recovered, and now it can conduct retrogradely. And so a short circuit, as I tell my patients, is formed down the slow, up the fast, and that is what the AV-NRT is. And when you look at the EKG, because the activation of the atria happens almost at the same time as the ventricles, you can hardly see a P wave that shows at the end as an R prime, or you don't see it at all. This is what we call short RP tachycardia, and usually it's typical AV-NRT. Atypical is when the circuit is formed with down the fast, up the slow. In that case, we're going to have a longer RP tachycardia. We can see the P wave past the QRS. and that can be part of our differential diagnosis when we have a long RP tachycardia. We are going to talk about the other mechanisms a little further down. So again, a PAC happens, it blocks down the fast pathway. So the PAC goes first down the slow pathway, up the fast, slow, up. And this is what we see on the surface EKG with that P wave that is very close to the QRS, and we call it short RP tachycardia. And this is an example. What I usually tell the residents, describe this EKG. And when you see fast, regular, narrow complex, it is SVT, and this is an SVT for this patient actually of mine, with a heart rate of about 120 beats per minute. So the AVNRT could be, the rate could range from as slow as this up to 200, 220 beats per minute, all depending on how good the conduction system of the particular patient is. This was an 85-year-old gentleman, so going down the slow, up the fast, going down the slow, it was taking a long time because he had AV nodal disease, but you can see that R prime, as we discussed in V1, that gives out the possibility of this being AVNRT. This is a more typical AVNRT, faster, about 150, 160 beats per minute, as regular, narrow complex. And then I'm trying to look for P waves. I don't see any P waves in V1, maybe a little R prime there. But if I look in lead 2, there are probably P waves just past the QRS. So kind of a short RP tachycardia again. And this was confirmed to be AVNRT when we took the patient to the cath lab, to the EP lab. Moving on now to the AV nodal reentrant tachycardia. So the way that it is created is by a short circuit that is created between the AV node, the natural conduction system of the heart, and an extranodal accessory pathway, which could be conducting antegrade only, retrograde only, or both. Usually it is both, antegrade and retrograde, and connects the atrium with the ventricle. If the pathway only conducts retrogradely, we cannot see the WPW pattern on the EKG, and that's why we call it a concealed pathway. And here is an example actually of an ambulatory monitor that I was reading like every week we read monitors for the hospital. I didn't know this patient. And this is what happened. Like this patient had this kind of wide complex QRS and then a narrow complex tachycardia, an SVT. And looking more carefully, you can see the P wave there with a short PR interval, like almost 0. And these downslope or upslope kind of slow upslope or downslope that we call delta wave, which has to do with the way that the ventricles are being activated first through the pathway. And then an SVT started, and we will talk about the mechanisms of the SVT. And so here we have the example of, again, the heart, a slice of the heart, the normal conduction of the heart, AV node, left bundle, right bundle. And here we have an accessory pathway. And when the person is in sinus rhythm, the beat starts from the sinus and it goes both down the normal conduction system and the pathway. But because the pathway conducts faster than the AV node, usually it beats the AV node. And so the heart, the ventricles get first activated through this area, and the activation spreads through this area. So the morphology is really like a PVC, essentially. So a wide, complex morphology of the QRS with this delta wave, as we discussed, that can be positive or negative, depending on where the pathway is and which lead is looking at the heart in which way. Wolf, Parkinson, White. Sometimes we use the names, but it's nice to remember that these are people that spent, who knows, years observing EKGs with that strange pattern and putting it together with symptoms that the patients had with palpitations. And actually, the steps here are the front steps in front of the old building of Mass General. So this is a historic picture, really. So how does SVT happen when we have an accessory pathway? So again, this is a diagram of a person who has a right-sided pathway. And what happens is the SVT starts when a PAC or a PVC creates some refractoriness in the AV node or the pathway. And for example, here, the beat goes down the AV node, up the accessory pathway. And here is this short circuit that can go pretty fast, 200, 250 beats per minute. And this is the most typical and most common. We call it orthodromic AVRT because the ventricles are activated first through the AV node. And so we have a narrow complex tachycardia. Whereas in 10% of people, we can have an antidromic AVRT down the pathway, up the AV node. So because the ventricles are activated first through the pathway, we have a wide complex QRS. And some characteristics that AVRT tends to go faster than AVNRT and is more prone to present with electrical alternance, and I'll show you an example of that. If there is any evidence of AV block or AV mismatch, there's no way that this is AVRT. AVRT, the A's and the V's have to have a one-to-one relationship. So here's one AVRT of a patient of mine, very fast, almost 280 beats per minute. Actually, this is orthodromic with right bundle aberrancy. Although it looks kind of wide complex, it was just aberrantly conducting. So down the AV node, up the pathway. And here is another one, again, clearly narrow complex. So down the AV node, up the accessory pathway. I wanted to point out the electrical alternance to you. You see how there is almost a beat-to-beat variability of the amplitude of the QRS, which happens because the heart is really quivering inside the pericardial sac, and it creates this alteration in the amplitude of the QRS. And as we said, fast, narrow, regular, and then we're looking for P waves. And I think I can see a P wave almost midway between the two QRS complexes. So this is what we call long RP tachycardia that can be either an AVRT or an atypical AVNRT or the atrial tachycardia that we'll talk a little further down. Two AVRTs that as electrophysiologists we need not to forget about because they have a special way of being ablated, but also have some clinical implications. When the pathway connects directly between the atrium and one of the bundles or one of the fascicles of the bundles, we call this an atriofascicular pathway or Maheim fiber, and it connects the right atrium with the right bundle. It conducts only antegrade, and sometimes at baseline there's almost no pre-excitation, whereas if they go into AVRT, that is an SVT with a typical left bundle pattern. The permanent junctional reciprocating tachycardia, or PJRT, is something that we should not forget, especially when very young kids, toddlers, babies, or sometimes older adults have. This can be incessant to the point that the first presentation of the patient is for heart failure because they develop tachycardia-mediated cardiomyopathy. It is very easy to ablate because the pathway is actually in a very accessible area, but someone needs to think about that when you see someone who's persistently 130 beats per minute. And like sometimes this can be confused with atrial tachycardia, but it's really an SVT. So after we see the EKG of the patient and we conclude that there is WPW pattern, for us, the electrophysiologist, the next thought is, where is the pathway? Because it is really very relevant to the procedure that we do, the ablation. And as you know, with the ablation catheters, we first reach the right part of the heart. So if the pathway is right there, technically it may be easier to get, whereas if it is on the left side of the heart, we may have to do a transeptal puncture or go retrogradely through the artery, the femoral artery, aorta, aortic valve, and retrogradely try to get to the pathway. So a little more challenging from a technical point of view. But this is where we usually see pathways. On the right side, right free wall, not so common. Posterior septal, very common. On the left side, the left free wall, these are actually the most common accessory pathways on the left free wall. And then there's also this small percentage of pathways in the anteroseptal area, so tricuspid valve, mitral valve, aortic valve, this area close to the His position that sometimes, although we know that they're there, we end up not even ablating because someone may end up with complete heart block. What now if a patient comes because they had to have an EKG to join the army, let's say, or to start soccer, and the EKG shows that they have a WPW, especially for young patients? What do you do with that? For a long time, we were saying, if the patient has no symptoms, even if they have WPW, we don't need to do anything other than clinical follow-up. And that may be true, except for children, people who play a lot of sports, intensive sports, pilots, school bus drivers, so people with positions responsible for a lot of other people. We may actually now say that we need to investigate more the potential of that accessory pathway to create trouble. So we get the baseline EKG. If there is persistent WPW pattern or intermittent pre-excitation, we may act differently. In general, we believe that when we see, even on the baseline EKG, that the WPW affects only some of the QRSs and other QRSs are normal looking, so intermittent pre-excitation, that is lower risk, more benign. That pathway probably does not have the ability to conduct fast. And in that case, if the person has no symptoms, then we may just follow them. But for, let's say, a 16-year-old kid who plays soccer semi-professionally, then we want to see what happens when they exercise. So when they exercise, does the pathway continue to conduct fast all the way to the peak heart rate of 190? If not, if it becomes intermittent after a point, then again, we say maybe follow up and look for symptoms in the future. But if that pathway continues to conduct very fast, then we may have to do an EP study. During the electrophysiology study, we do certain things like we try to induce AFib. So to see what happens if that person goes to AFib, how fast they are going to be conducting. Or we pace the heart, the atria fast, and we'll see how fast that pathway conducts. If it conducts over 280 beats per minute, then it's a very high risk pathway. And actually, we may want to ablate while we're there. If not, we make this discussion with the family before. What would you like us to do? Most of the times we say, if the pathway is there and it's easy to ablate, we will ablate, and we agree on that. So what I have just described has been incorporated in the guidelines. The most recent SVT-related guidelines are the European Society of Cardiology, 2019. And it says exactly that, as we discussed, as we were talking over the previous table. Okay, here's the example of intermittent pre-excitation. So you get a rhythm strip of the patient, and other complexes are pre-excited, others are not. So this is a low-risk situation. Here is constant pre-excitation on the baseline EKG, and then I took this person and put her on a treadmill. And what was happening as the heart rate increased, you see the pre-excited, the delta waves are still there and there. And so this is a high risk accessory pathway. We should do an EP study, even if the patient does not have symptoms. So WPW, with the potential of creating arrhythmias, SVTs, as we discussed, what we really don't want to see is WPW and atrial fibrillation. And in that case, this is how sudden cardiac death arrest can happen if the person starts conducting like 300-400 beats per minute. This can degenerate into VF. And some differentials. So when you see a person with a wide complex fast rhythm in the emergency room, could it also be VT? Usually RVOT VT, so a benign VT could still be a wide complex tachycardia, or aberrancy in the setting of AFib or flutter. And these are the situations that we may have to use our judgment and knowledge. And this is what happens with AFib and WPW in a real-time situation. And as I said, this can lead to cardiac arrest. Finally, a few words about atrial tachycardia. So a fast rhythm originating from somewhere in the atria, a spot that keeps firing faster. And this is a surface EKG in sinus rhythm and during the tachycardia. And this is a catheter that is actually in the right atrium. And you can see how sinus looks. This is the P wave, and this is the far field QRS. And this is what happens when the person goes into the tachycardia. You could see 2 P waves for every QRS. Atrial tachycardias, as we discussed, they are less common. They could come from anywhere inside the heart. People that may have some underlying cardiac disease, COPD, previous infarcts, heart failure, can be more prone to ATs. They're usually not super fast, usually less than 200 beats per minute. And on the EKG, they look as long RP tachycardias, as we will see here. So here, the sinus node for this patient is up here, and all of a sudden, this spot starts firing, and it creates this EKG. And it's really a long RP tachycardia with a normal, almost PR interval. And finally, atrial flutter, which is a reentrant rhythm inside. If we talk about the right atrium, usually around the tricuspid valve, and here is the reentry around the tricuspid valve, and the sawtooth presentation in the inferior leads V2, 3, and F, and the positive P waves in V1. This is a typical atrial flutter that goes counterclockwise around the tricuspid valve. And here is an EKG, a real-life EKG. And here is an atypical atrial flutter that could be some reentry anywhere else. For example, this was a patient of mine that had a flutter around the mitral annulus, and it has a different EKG than the one that we discussed. A few words on inappropriate sinus tachycardia lumped together with SVTs. Usually it is due to hypersensitivity of the sinus node or some reentry around the sinus node. And the bad thing with it is like it can be constant and refractory to medications. So we define inappropriate sinus tachycardia, a persistent sinus tachycardia more than 100 beats per minute during the day, with excessive rate increase in response to activity and nocturnal normalization of rate as confirmed by Holter. The tachycardia and the symptoms are usually not paroxysmal, they're constant. The P wave morphology looks like the sinus morphology, and to call it inappropriate sinus tachycardia, we have to exclude hyperthyroidism, pheochromocytoma, deconditioning, and other things. In terms of the management, of course, ruling out secondary causes and reversible causes. We use the usual antiarrhythmics, beta blockers, calcium channel blockers, even more advanced antiarrhythmic agents. But I want to specifically talk about ivabradine, a newer agent that has is a selective inhibitor of the pacemaker current. So it really acts only on the sinus node. And it has been shown to really decrease the heart rate on average by 10 or more points on someone who's persistently tachycardic. So it's not only good for inappropriate sinus tachycardia, but also for decompensated heart failure when patients are constantly tachycardic, with good results, even mortality benefits for heart failure patients. In terms of the management of the SVTs, we talked about the IST, but let's talk about AV nodal reentrant tachycardia, AVRT, or AT. Even before the patient decides to come to the office or the emergency room, they have to try vagal maneuvers. Most of these tachycardias are AV nodal dependent, and we know that vagal maneuvers affect the AV node conduction, and it can terminate many of them. So bearing down, put cold water on their face. Usually I don't ask the patients to do carotid massage on their own or to press on their eyeballs, but vagal maneuvers can be very effective. Let's say that we did it and it didn't work. Then once they come to the hospital, adenosine injection terminates 90% of the AVNRTs and AVRTs, but even also some atrial tachycardias. And it's a very short-acting medication. So although it gives patients symptoms of hot flash and shortness of breath, and they don't feel well with it, the effect goes away almost immediately. And you can see an example here that after the adenosine was given, the SVT terminated with a little atrial fibrillation that was created. And the same here, the SVT is going on, the person is getting adenosine, then there is a little ventricular ectopy because it decreases the refractoriness of the atria and the ventricles, but then in a few seconds, the effect is going away and the patient is in sinus rhythm. If there's no adenosine, or if adenosine was given and the SVT keeps coming back, then we can give longer acting medications that will cover the patients for at least a few minutes until we start giving them oral medications to suppress the SVT. Intravenous metoprolol, intravenous verapamil, or diltiazem can be used. And this is a scheme that shows what to do, as we discussed. But if all of those are ineffective and the person is really unstable, we can shock them out of SVT. Why QRS tachycardia? It becomes a diagnostic dilemma. Is the patient in VT, or are they in SVT with aberrancy or down pathway and up the AV node. We can still give adenosine if it is available. As I told you, it's short acting. So even if someone is VT in VT and we give adenosine, the effect is good. There's not going to be any downside. But we should not give verapamil intravenously. We should not give digoxin intravenously, because actually they can make the situation worse with hypotension or facilitation of the conduction down the pathway. Really, the treatment for wide QRS tachycardia is trying to block the conduction down the accessory pathway if it is an antidromic AVRT. And the same treatment could be used for ventricular tachycardia. So intravenous prokinamide, actually now our ACLS algorithm suggests intravenous amiodarone first, but intravenous prokinamide can be used. And of course, if the person is unstable, then external shock. And this is the scheme as we discussed. And for chronic therapy, someone who has had palpitations a few times a year, and we decide to treat them with medications, calcium channel blockers, beta blockers, high efficacy, low adverse effects. And sometimes when they are very resistant to this first line of medications, we use proper antiarrhythmics like flecainide, propafenone, or sotalol, and electrical cardioversion anytime that there is instability. A little bit about atrial flutter, similar treatment as with atrial fibrillation, rate control versus rhythm control, and of course, deciding on anticoagulation if we have to. A few words about pregnancy. SVTs are more common during pregnancy. PACs, PVCs, SVT episodes. We try to avoid, if possible, all drugs in the first 8 weeks of pregnancy, but also during the second or the third trimester with medications, we can have an effect on fetal growth and development. And we keep that in mind. Some things that are considered absolutely safe: vagal maneuvers for SVT, adenosine injection, cardioversion, all these are safe and class 1 indication. Beta blockers have been studied for many, many years, and they are safe: propranolol, metoprolol, same with verapamil, digoxin, for prophylactic medication, metoprolol, propranolol, and even some proper antiarrhythmics. The ones that we do not want to use, atenolol and amiodarone, they can really have a bad effect on fetal development. And these are the European guidelines from 2019, essentially repeating that older table that I showed you in terms of the classification of the indications for treatment. Side effects of medications during pregnancy: even beta blockers can cause bradycardia to mom and baby, hypoglycemia, premature labor, metabolic abnormalities. Atenolol, we try to avoid it throughout the pregnancy, and some medications that we rarely use, quinidine, we don't use it that much, but amiodarone is only for life-threatening arrhythmias if we have to. But what we really like to talk about to patients with SVTs is our ability to cure their arrhythmia. Everything that we have talked up to now is to terminate temporarily an arrhythmia, knowing that it's going to happen again sooner or later, or to suppress it with medications long-term. But we know that the medications work about 70% of the time. The patients can still have breakthrough episodes. Catheter ablation is when we get into the heart from the venous axis down in the groins, up you see here the IVC catheter inside the right ventricle, the His bundle area, the high right atrium. Also, we put a catheter behind the left ventricle in the coronary sinus, and we study the electrical properties of the particular patient. We induce the arrhythmia, and we study which one of the mechanisms is responsible for the particular patient's symptoms. And then with one of the catheters that can deliver radio frequency or cryoablation, we'll talk a little bit more about that, we can go to the spot that we have identified that is causing the problem, burn or freeze that spot, and really cure SVTs. So we're really very excited that we are going to be doing some more. We have already started some more SVT ablations in your areas. So indications for ablation, it is really an attractive alternative for patients who either desire or to have it or are unresponsive or intolerant to drug therapy. Certain indication for high-risk WPW, women, especially women that are going to have more pregnancies, and we know that they can suffer more from SVT, young patients, teenagers that are going to have SVT for the rest of their life, high-risk occupation, or patients who get the SVT and they really don't feel well with chest pain or heart failure, and also patient and physician preference. For the AV-NRT, we know exactly where to go and do the ablation. Like, we don't even need to do any particular mapping for each one of the patients. We know where the slow pathway is. And so this is a little harder for you to see, but this is a fluoroscopy with our catheters inside the heart. So this is a catheter in the right ventricle and a catheter in the right atrium and in the his area. And we have this imaginary triangle in our mind, with the one angle being the his, one side being the tricuspid annulus. We call this triangle of Koch. And this is where we know that the slow pathway exists for most of the patients. Remember, we said about dual AV nodal physiology, a fast pathway and a slow pathway, and the reentry goes between the two. So we go and we modify with ablation applications the slow pathway, and that takes care of the problem. We don't even need to completely ablate it. So we go in this area, we do our ablation, 4 or 5 applications maximum, and this person never has AV-NRT again. For AVRT, this is an example of a patient of mine that we took to the lab. You can see the pre-excitation delta wave in V1 and negative delta wave in 2, 3, and F. For AVRT, first of all, this study says that even if someone with a WPW is asymptomatic and you take them to the lab, you can still induce AVRT in a great portion of them during the EP study. So then you're justified to do an ablation, whereas if you don't do the EP study, sooner or later, they will return with symptoms, a great majority of them. And some demographic observations on patients with asymptomatic WPW, that there's still a risk for sudden death, as we discussed. So for AVRT, what we need to do is to place our catheters and really be able to locate where the pathway is, depending on the activation sequence from the various recordings of our catheters. And I will not go into great detail here, but this is what this recording shows, and the retrograde activation sequence as the patient who is already in an SVT. And by looking into this, I can say that the pathway is actually on the left side, the posterior mitral annulus. And so you bring your catheter to that spot, you go on ablation, and the person is cured for the rest of their lives. So again, a schematic of this, how that first person with the right accessory pathway, when you come with an ablation catheter here, you can terminate the SVT and really, really injure or damage this accessory pathway for life. With atrial tachycardias, as you remember, it's one spot inside one of the atria. We have to find that spot. We do have some nice mapping techniques. This is the electroanatomic mapping that can color code activation sequence. So very early is red, very late is purple. So you want to go where red is and put your ablation points there to take care of the tachycardia. And for the flutter, remember, is a reentry around the tricuspid valve. We actually ablate across the isthmus that is formed between the tricuspid annulus and the IVC, and that terminates and cures a typical atrial flutter 95% of the time. And this is how the catheter positioning is. Downsides from ablation, I usually tell patients 1 to 2% for anything to go wrong, but we do mention a lot of, horrific things like cardiac perforation and tamponade. I don't remember the last time we saw that, or complete heart block. I think in the 25 years that I have been doing this, I have seen one case that we knew that this was going to happen, but the SVT was so refractory that we had to do it. And vascular complications, I would say, and death, I would say, impossible. In terms of success rate, AV and RT is really up to 100%, with a 1 to 2% recurrence rate, in which case you can go back another time and do the ablation again. AVRT is, I would say, over 95%. Atrial tachycardia can be a little more elusive, but I would say over 90%, and flutter over 95%. Sources of energy, we can either burn or freeze, radio frequency or cryoablation. The difference is with cryo, you start freezing most proximal to the catheter and transiently deeper and deeper. So if you realize that you are creating heart block, for example, you can stop, and that can be reversible. Whereas with RF, it's a little less forgiving, but it creates a deeper and more enduring lesion. And that's why we prefer it for most of the ablations. But those are the two options. And here's an example of cryoablation. During SVT, the ablation went on. A few seconds later, the tachycardia terminated. You complete the ablation and the application, and you are done with the SVT for the rest of the patient's life. I think I will end somewhere here. I have left maybe 2 minutes or more, as many as you want. I have plenty of time to talk, to answer any questions that you may have. Thank you all. Thank you for sending me your notes. And hopefully we will see each other again in another of these talks or in person over the course of the year. Thank you very much all.